she can turn it over to Clayton. Thank you so much, everyone.
Thanks, everybody. So I'm going to share this with you now. Hopefully you can all see my screen. So we will be recording this. I did just hit the record button, so hopefully you have all consented to that. I think most of you have been on here before, so you're familiar with it. And this is, again, something that we hope you will remember just as we walk through this, to please mute your phone when you're not speaking. Make sure your webcam is positioned so that we can actually see you, because that really helps. And then again, use the chat function, which I found up on the right-hand corner of my computer, to be able to ask questions and participate. So again, we want to protect the privacy of the people that we're talking about. Please don't use any names of your patients or any identifying links as you talk through them. We really don't want to talk about, again, names, locations. Don't be using specific dates, where they're employed, any of those kind of things. Let's just kind of keep it broad as we talk through case studies. So as we said, we're really excited to have Clayton LaBaume here with us today. He's going to help talk through what are some of the elements of success as we go through the FLS pyramid plan. And as we said, we'll let Clayton kind of introduce himself a little bit, and then he'll take over the presentation. And let me see, Clayton, if I can unshare so you can share now. Are you able to share, Clayton?
I am.
All right.
All right. Can everybody, let me switch screens here. All right. Is that working out?
Yeah. I can see it.
Yes. Yeah, we can see it.
Perfect. So, first of all, thanks again for having me on here. My name is Clayton LaBaume. I'm a physician assistant here in Durango, Colorado. I work in an orthopedic practice with Dr. Furry. I believe she's on here as well. Just kind of give a little bit of history with kind of where our program started. This was kind of a vision that we'd had for a long time. It was a work in progress for quite a long time. And our program actually started with a geriatric hip fracture program. We saw a big need to kind of improve the quality of care that we're giving. So we started with a protocol-driven geriatric hip fracture, and we're looking at improving certain markers. We're looking at improving our length of stay. We're looking at improving time from the door to the operating room, mortality rate, cost, all these different factors we're looking at improving specifically with hip fractures. And we saw such a good improvement. We're part of Centura Health. It's a 17 hospital system in Colorado and in Kansas. And we saw such a dramatic improvement throughout our system with our hospital that we ultimately decided to go live with this geriatric hip fracture program system-wide. And we've subsequently seen, improvement in all those markers. And so about, 5 or 6 years ago, kind of the next natural progression was development or implementation of FLS, fracture liaison service. And so, we started out, we scaled the program down. We started out initially just really capturing the inpatient fractures. Our biggest goal was to capture the hip fractures, and we tried picking up as many of the hospitalized fractures that we could. And I first joined in this clinic going on 3 years ago with the intent of growing this fracture program. And, I started off working the bone health clinic half day once a week. But my goal was to gradually increase the program, and throughout time, my time spent doing bone health has increased to where I'm almost doing it full time. I'm still in the operating room a couple of days a month, and I'm transitioning out of doing other orthopedic stuff. And we're going live with telemedicine, where I'm going to start doing patient visits online. So it's really grown, but I kind of wanted to share my story because I think it could be really motivating to hear other programs that have been successful and are working. It's possible. If we can do it, anybody can. So moving forward, these are my disclosures. Objectives are to review key components and steps for FLS implementation using the FLS pyramid plan for success model. This is something I developed for the Santa Fe FLS bootcamp. It's kind of a way I just organized all the components, and we'll be covering this again in the FLS bootcamp that will be in Denver next month. So as I mentioned, FLS can work for you too. It's certainly worked for us, and we've proven that our program is successful. So this is what the pyramid plan kind of looks like. We'll kind of review each of the components. So at the top, mission and vision. This is overall, what are we trying to accomplish? It should be clear and simple. And essentially the mission for any FLS should be to enhance care of patients following a low trauma fracture and close the gap, the treatment gap for population at high risk for future fractures through the fracture liaison service coordinated model of care. We often talk about the mission, but I think it's really important to look at the vision as well. Where are we going to be? We're going to start with a certain scope of program. How's that going to grow? Where do we see ourselves a year from now? Much less, 5 years from now. Strategies, these are going to be, how are we going to sell the program? So looking into these a little bit further, the market opportunity. This is why we are trying to create this program. So, all these steps are going to really lead to getting approval for moving forward with the FLS. So, using the pain, we often use real life stories. I mean, just today I was going through one of my patients who's had, I want to say like 5 or 6 fractures, including 2 hip fractures. She's never been treated for osteoporosis before. And I was like, this is a perfect example I can use later. I'm constantly seeing these real life stories that really show the gap in care. The product or service. This is where we describe to the C-suite or the administrators or the practice administrators what the FLS is and show them evidence that FLS can work. We can also show that FLS runs parallel with our organizational mission statement. Identify risks, both strategic and financial risks. Also proof of success, demonstrate success, successful outcomes, both financially and clinically, I think is pretty important. Moving to the next tier of the pyramid plan for success, goals. We talk oftentimes about a baseline audit, determining what your goals will be and how we're going to measure and track those goals. So with a baseline audit, it's recommended, but it's not really firmly required. Oftentimes getting baseline information can be really difficult. Sources used to obtain information often comes from EHR and billing systems, and it can be used to, for one thing, prove that there's a need, but also prove success with implementation of the FLS. I always caution people, all these things are important components, but none of these things are, especially with the baseline audit, it's not absolutely required. If you want to go live with an FLS, don't use the inability to get baseline information as an excuse for not moving forward with your FLS. You can often get retrospective information if we need to. We can also prove that we're being successful after FLS implementation by proving that we're doing a better job than national statistics. So determining goals, what will your goals be? It really depends on the scale of your program. It should be simple and achievable, and how you measure and track your goals. Again, is it going to be the number of people that you capture and identify, the number of people you tested, the percentage of people you have treated? Are we going to look at mortality rate after they have their fracture? These are all things that need to be considered. And the way that we track how successful we are with these goals is with our registry. And to the next tier of the pyramid, financial considerations. So this is where we come up with our business plan, our financial business plan. So, some considerations need to be FLS expenses, income, including potentially new sources of income like downstream revenue with labs and imaging and referrals. Also, something we need to consider is potential, income at risk with current care, and potential incentives for providing better care. So again, we have to determine the projected expenses and income, and a really good tool that's on Fracture Prevention Central is the return on investment calculator. You can go in there and you can put how many fractures that you see. It could be really helpful if you have baseline information. If not, even a rough estimate can be helpful. You put in there how many of what types of fractures you have and exactly kind of what the scope of your program is going to be, and it can kind of calculate return on investment, which can be really helpful, especially in the approval process of your FLS. So the next tier is the key components, which include the team, the stakeholders, and also the registry system. So, the team, as we know, physician champion, FLS coordinator, the nurse navigator, support staff, and the administrative champion. Stakeholders include multidisciplinary stakeholders, which includes everyone from all the specialists who treat osteoporosis, the primary care providers, the pharmacists, the physical therapists, the radiologists, the pharmaceutical companies. So there's a lot of different folks who are stakeholders with this plan. The registry can be formal, such as the LaBaume or the NBHA, the Quality Improvement Registry, or an informal spreadsheet. And oftentimes, as people are first getting their programs up and running, oftentimes they use the informal spreadsheet. So we also have to look very closely at what information and what type of data needs to be collected. And there's some really good resources on NBHA website in regards to that. The final tier is kind of the operations. This is the workflow, the structure, the tactics, how we are going to do what we're going to do on a day-to-day basis. So looking at this, the workflow structure, again, it determines on the scope of the scale of your program. So, is the goal going to be to start capturing all the fractures, or is it going to be with a certain subset like hip fractures, with the plan to slowly increase that to include the hospitalized fractures? Maybe the next type of fracture you're going to include is going to be the vertebral fractures. How are you going to grow your program? I speak to a lot of people who started out successfully with a full-scale FLS, and they were successful with it. Also, the scale of the registry and the reporting. Is it going to be that local kind of spreadsheet? Is it going to be regional, where we're part of a hospital system within the region of Colorado, and we're looking at how we're doing compared to other hospitals within the same system in the same region? Or is it going to be national? And that's really where the formal registries come in. So the tactics, that's day-to-day operations, determining protocols, things to consider like how are patients going to be identified, how will the workup be done, when will the workup be done, are we going to accept referrals from the community, all these little things that really need to be decided on. And again, what you choose on day one might be different, the second year, third year, fourth year that you've kind of rolled forward with the FLS. So, these are kind of general action steps. Are we going to bring anybody else to the table? And, especially the multidisciplinary stakeholders, administrative champion, developing a business plan, determining the scale of your program, identifying the team, identifying patient subsets, creating educational materials. That's something you can start working on now, so that way by the time you do implement your FLS, all that stuff is ready to go. Determining existing resources, which personnel can be utilized. Oftentimes we talk about projected costs, and a lot of those costs are things that your practice is probably already spending money on, or shared personnel as well. So oftentimes, starting with FLS can be less expensive than what's often thought. Get PCP specialists and other stakeholders involved. Educate about what FLS can do. Educate about what our goals are. And finally, determine how data will be collected. So that's really it, kind of in a nutshell. Once again, with the boot camp, we'll definitely plan to go into each one of these components into a lot more detail. One thing I also like to kind of discuss and spend a lot of time on is getting past barriers, because I meet a lot of people who want to get started with an FLS, and they always say, well, we've been wanting to get our FLS started, and there's always something that's keeping them from moving forward. And so we'll spend a good 30 minutes or so at least, I hope, on discussion in particular about ways to get past those barriers. Questions?
While everybody's thinking, I just want to say that, first of all, thank you for your presentation. And I'm sorry, I don't know why I had New Mexico on my mind. I knew it was Colorado, so I apologize for that. But
we're close. We see a lot of people from there.
Yeah. Thank you for your presentation. I just want to tell everybody on the call, obviously, this is not an exclusive group. We expect to see new faces, new names, new people. We expect to see return people coming on to FLS, Project Echo. So we want you to feel welcome. We want you to feel invited, but we don't want you to feel, if you're new, that it's an exclusive group. We want you to be able to have input in what we're doing. And so really today's presentation really is just a presentation about what Clayton's been laying out in his practice to close the fragility fracture treatment gap. And what I love about his approach is that it really is a team approach. I know Dr. Fury is on the call, and they have an excellent team there at his location and in Colorado. And they built this really strong fracture liaison service with great physician leadership and also a strong advanced practice provider. But I see other people on the call, and we love it. We love the diversity of the people on the call, and we want everyone to feel welcome. So part of that team approach is just letting you know that once we hang up from this call, that we also have FLS consultants, and actually Clayton is one of those, Amanda Brown is one of those, and we have Dudley Phipps who's also on the call. So there's people that you would be able to talk to after that. So I just want to open it up now for discussion, and then we're going to have case presentation, but I want everyone to feel welcome to speak up.
This is Kim Furry. If nobody else wants to say anything, I'll echo what Ann said about the collaboration. It's really important to have a strong team. Clayton's been with us for 3 years, and despite me being a champion, I had a PA that was interested in it but got burnt out on it very quickly, and so it kind of plateaued, and we were kind of doing my patients and some of the hip fractures from the hospital. But having so you need a physician champion to get going, and then having a really engaged mid-level provider that really wants to take the ball and run with it, then there's no limits. But having that collaboration in the team are really important.
You make a great point, mainly because it's best utilization of everyone's skills. My orthopedic surgeon, he's very skilled in the OR, and he can recognize these patients. But I had a patient come in this morning, and she said, I asked him if I should go back on my osteoporosis medications, and he looked at me and said, you need to see Ann. So yes, it is definitely a team approach, and it's utilizing all of our skills to the best of their level. So thank you for your comments, Dr. Fury. That's very important. We have there's a hospital administrator. I think, is it Ms. Hirschberger? I wanted to ask you if you could tell us, do you all have an FLS in your facility?
I'm an administrator of a practice.
Okay.
As well as we service facilities.
Okay. And do you have a fracture liaison service in your practice or in your facility?
No, we're trying to start one.
Okay, fantastic. We are so glad you're on today. So hopefully this has been helpful, and certainly I hope you follow up with us. So that's great. We have a lot of people that can help provide you some insight.
Well, we work with a group that does in-home care and also services 15 facilities, both assisted living and independent. So we have a huge group to draw from now that we're part of that.
Oh, absolutely. Do you have do you have an advanced practice provider that would be interested in taking on that role there?
I think one of the ones on the team is going to, because between their group and mine, we have about 9 nurse practitioners.
Okay, wonderful. Well, please let us know. Like I said, we've got FLS providers on the call. We have care coordinators and navigators on the call. We have other administrators. So whatever we can do to help you guys get up and rolling, we're happy to help. It's like Clayton was talking about, those barriers. We can help you get rid of a lot of frustration way ahead of time with all of the experience that we've had. So we're glad you're on today. Any other comments about the presentation before we go?
No, I think it was very good. I have all the materials from ISCD with their class, but I wasn't able to stay the whole time.
Okay.
But I do have all of theirs, and I teach for the state of Ohio, so density.
Oh, wonderful. Clayton, do you have any anything you want to share with her about other resources that you have or have used to get going?
So there's some pretty good resources on NBHA. Now, I'm happy to share patient educational materials that we use. I think that can be really beneficial. That's something that I'm always have been very open about sharing, because we're all trying to accomplish the same thing. I think that really moving forward, I think it could be beneficial to the one-on-one consults. I think is a pretty useful tool, because you can talk to somebody who's already kind of been through there and developing and growing their FLS, and they can help you, because not every single facility or institution is going to be the same. There's going to be different challenges at each one, and chances are somebody's already gone through that. Somebody already knows how to get past those challenges. So I think that that's a really useful resource.
Thank you.
We'll be sure to follow up with you. We'll follow up with you to see what we can do to help you get things going. So again, we're so glad you're on. Anybody else in the starting stages of an FLS?
Thank you so much.
You're welcome. Anyone else in the starting stages?
The other thing I'd say, Ann, this is Dr. Furry again, is site visits are really helpful. I mean, when I was trying to get going with this, I went out to Rochester, New York, and hung out with Steve Cates, one of the orthopedic leaders of the inpatient geriatric fracture program, and his nurse practitioner. And Clayton's done the same thing with Paul Miller and various people. And so I think the site visits are very helpful too, just for knowledge on interaction with the patients and what to do, but also how to set it up and how they run the clinics.
Yes, thank you. Actually, we do know Paul Miller very well, and Stu Silverman, and we are doing a study with them with the NBHA, our holiday study.
Very good. Well, like I said, we'll be sure and follow up with you and make sure that you have what you need to get more traction and keep things going, because we want you to be successful and have a sustainable program as well. So great comments. Thank you, everyone. I think we can go on into the case study if we're ready. I believe, is it Dr. Good? Do you have the case study today? Yes. Hello,
yes.
How are you today? Good, thank you. We'll let you go ahead and get started.
Okay, I'll be brave and undo my video too.
There you go.
Okay, so this is kind of a, anyways, I'll just get to it. So I saw this lady on Monday this week. She was new to me. She's 73 years old, female. She went through menopause at 51. She's a white female. And my main question is it okay to start an anabolic after she had a zoledronic infusion about 3 months ago? And I guess I'll jump to the reason why in the beginning. She was sent over to me by a neurosurgeon in town, and his referral was in May, and he wants to do surgery on her. And I don't know exactly what type of surgery because the patient wasn't very clear, but she said a potential fusion at some part and then other various different spine surgeries, but he felt like she needed to be evaluated and treated and have her bone stock improved before he was able to do the surgery. So he sent her to me with what I would assume to be the intention of starting an anabolic, because generally when you get referrals from him, that's what he puts them on, is an anabolic. And so in the meantime, before she actually made it to me, she took it upon herself to go see a rheumatologist who gave her a dose of zoledronic acid about 3 months ago, and then she followed up with me. So that's the background of her. She's otherwise active and in good health. She has had a couple of falls. This is per patient, an MRI done by the surgeon's office. They did find a lumbar compression fracture. I don't physically have a copy of this report because I saw her on Monday. It's just what she's telling me. She has some reflux and colitis. She takes some Synthroid, Pepsid, Topramate, amitriptyline, escitalopram, simvastatin, cyclobenzaprine, and sumatriptan. She's had her one and only dose of Reclast on June 26th of 18. She's otherwise taking medications for osteoporosis. Doesn't smoke, doesn't drink. Her height and weight is 5 foot, a little over 5 foot, 1 pound, 6 ounces.
Can you go to the next page on her? I need to see the next page. I can't see it.
Oh, I'm sorry. How do I do that?
Well, I thought, Andrea?
Andrea, can you click through that?
Give me 1 second. This one? Or the other one?
There you go.
Two of them.
Okay. No, that's, yeah, that's it. Yeah, okay, go ahead. Go ahead, Dr. Good.
So her height and weight, she's otherwise normal, walks without assistance. I didn't do any vertebral imaging because she was sent over by the neurosurgeon. I felt as though he had adequately done vertebral imaging on her. And she had that, what she told me was her lumbar MRI. Her DEXA was from May that he ordered, and her T-score in her lumbar spine was negative 2.9, negative 2.6. They didn't give me a femoral neck reading or a distal radius reading. I didn't do a FRAC score because I didn't have a femoral neck reading. I did draw like 5 of those back when I submitted this. I didn't. And I got a metabolic panel that was stone cold normal, as well as her CBC. Her vitamin D was 53.2. Her TSH was 0.149. So she's on Synthroid. I'll just make sure she addresses this with her primary, who has her on it. Her phosphorus was 4.8, so a little on the high side, and her magnesium was normal, and her intact PTH was normal at 30. So my question is, can I do anything for her to get ready for surgery, or will the Reclast be enough for her? What should I do in terms of improving her bone stocking quality the quickest so that the surgeon can do his surgery?
Okay, that's a great question. So the phone lines are open, everyone.
So, I do, this is what I think. I think that there is, still some potential benefit even though she's gotten the zoledronic acid. Because teriparatide can really help decrease the risk of pedicle screw failure, can increase fusion rates. I mean, we know all the data. And I would still consider it in this patient even after they've gotten the zoledronic acid three months ago. One thing I would do, I think that this is potentially a really good place to consider using bone turnover markers. Because, while zoledronic acid, I mean, it affects their bone turnover, what I would just really like to ensure with what we know about sequential therapy now, I would like to just be sure that we are getting a good anabolic response. So I would like to see a good improvement in their P1NP, preferably at least 40% above baseline, even 1 month after starting treatment. And that'll give us a good idea that the anabolic medication is working. That's my take on it.
I did order a P1NP. It's still pending. It hasn't come back. I have not ordered a CTX. Just truth be told, I've kind of gotten scared too, because I've had several people come back and their insurance wouldn't pay for it, and I get some unhappy customers with that. So I held off on that for now. But I have a P1NP coming. It just hasn't been resulted yet. So you think it's okay to go ahead and start? I've sent her home with the Forteo. I just told her hold off on starting it until I, give her a call, because my real concern is there going to be any sort of blunting effect of the anabolic after having the zoledronic acid? Would it be better for me to wait a while? And I don't know how long that while period is, but before I started the anabolic, would she, it would take longer, but would she have better outcomes if I waited to start the anabolic after a certain period?
Dr. Good, I think that you're in a situation where you are actually in a perfect world here, because with her age and with her history of spinal fracture in the past and with her current BMD, you're basically doing concomitant therapy, which is really what's been discussed. So I would absolutely have no hesitation starting an anabolic on her. I think what you'll just need to do is like Clayton was mentioning is, I would definitely keep an eye on the P1NP. The CTX, you've got to get that. It's a very it's not unstable. I don't know what the right word is, but you've got to get it first thing in the morning. It's got to be fasting. It's just it's very different test. So I think a P1NP is certainly good. But since she just got the zoledronic acid, the CTX, I'm not so sure it's really going to tell you a whole lot. But you can certainly see the building response with the anabolic if you chose to go that route. I want to ask Dr. Olenjinsky, if you, as a rheumatologist, if you could speak up with your experience of reclass, if you have any comments about her question. He's still on. Are you there? He might not still be on. All right.
We did lose one, Ann. I don't know if I don't see him on.
Okay, that's fine. We might have lost him. So yeah, that would be my, we have other providers that are on today. I don't want to call you out, but I know you're very well capable of answering the question. So, Dr. Fury, do you have any comments about it? I'd love to hear your thoughts as a surgeon.
Yeah, I would say the same thing as Clayton did. I'm not a spine surgeon, but certainly the anabolics have been demonstrated to help with minimizing pedicle screw pullout. And our spine surgeons actually use Clayon a lot for preoperative treatment prior to proceeding with spine surgery for that exact reason. And I don't think there's any reason to not do that for the benefits of it,
Okay.
despite being given reclassed.
Okay, great. Does that help you, Dr. Good, to sort of give you a little treatment direction? And
it does.
Okay.
Question
Wonderful.
is, I normally see him back in 3 months and get the follow-up P1NP. Should I see him back sooner, or is 3 months okay?
No, I think getting it pre-treatment, if you're going to do the anabolic, and then pre-treatment, and then getting it at 3 months. One of the other things you can do, obviously my thoughts would be to keep her on the anabolic for the full 24 months of treatment.
Right.
But if for some reason there's a question or whatever, I would at least treat her for 3 to 6 months, since she still has the Zol for her osteoporosis. You're trying to get the other benefit. So, if there's an insurance coverage problem or whatever, you might have to sort of be creative in that. But I definitely think that I would try to keep her on it for the 24 months, but 3 months should be fine, I believe. Yeah.
Okay.
Great. Any other comments before we go to the I think, do you have another case presentation, Dr. Good?
I do, if
Okay.
there's for it.
Yeah.
Can I make one comment on that real quick?
Yes, go ahead.
So one thing, I hear a lot of times, I've had a little bit of difficulty getting CTX covered myself. And I was advised this a while back, and I haven't really had as much of a hard time since. If you use diagnosis disorder of bone, it's usually covered So you can use that in addition to the osteoporosis.
It's just that, like, maybe once or twice, and here lately, even the P1NPs, I've gotten a deny, they won't pay for it. So I'm kind of leery. I figured out that where I am, plain Blue Cross pay for they find it educational and necessary. And so no matter what I do, I just absolutely cannot order it because the patients are going to be footed the bill. But it's been a while since I've ordered the CTX because I've been afraid of it, because I've gotten a few people.
Yeah, and I think that, that's really something that we need to work on a national level. If they want, if our standards, if they're telling us best practice is to order those, then we need to get those covered. So we, that way in clinic, we can actually do what's best practice. So I agree. I haven't had any trouble with P1NPs, but definitely CTXs. So I wanted to tell you there were a couple of other comments that were in the chat. I guess, I don't know if somebody just doesn't have they can't, I don't know what it is, but I'm going to read it. So there was a response that said that one of the providers says they've had several patients that have been in the same scenario, and they've seen a really good response with teriparatide despite having been exposed to recent anti-resorptive therapy. The other question was, and I think this is a question for the group, and I think, any one of us can certainly answer this, but I think it's a great question. The question for the group is, if you are going to choose an anabolic for this patient, which one would you choose? And this question is, given the rapid bone building for Tymlos, would you not consider, well, I should say abaloparatide. Giving the rapid bone building for abaloparatide, would you not consider abaloparatide over teriparatide as the surgery is upcoming in the next few months? Does anybody have any comments about that?
Most of the work's been done with teriparatide.
Okay, who's that? Who's that? Is that Michael?
Yeah.
Oh, okay.
Yeah, I think most of the studies were with teriparatide.
Okay.
Logically, you would think Tymlos would work better, but you really don't have the information on that.
Okay. Yeah, so really in answer to the question then, it's really more data-driven with teriparatide than abaloparatide in terms of outcomes and spinal surgery. So, yeah, there's more to be done. So that's a great question. Any other comments about that? All right. Well, we can go on to the next. Oh, go ahead.
Hey, Dr. Lake. Hey, it's
yes.
Lisa.
Yes, hey, Lisa.
Right. Hi, sorry, I couldn't get off mute earlier. So that was my question. So I do the P1NPs and the CTXs on all of our patients, and I've seen some tremendous responses with abaloparatide. So I was, just thinking personally, we have a lot of spine cases as well, and my thought is perhaps my choice may be abaloparatide over teriparatide because of what I'm seeing from the bone turnovers. So, and the P1NP. So that was my question and thought, and I just wanted to clarify that. So yes.
Perfect. Thank you.
Sure. Thank you.
All right. Well, we'll go on to the next case presentation. Andrea, if you could get that pulled up for us, that'd be great.
Is the one open right now? The one you went over before was 9:10, and the next one is the 8:30 exam.
Sarah was going to have to tell us that one because.
Okay.
Oh, this is a different patient.
Yeah.
Yeah. Okay. Dr. Good?
Yeah. The front page of this, I'm showing the second page of this one on the screen.
Yeah, go to the first page of that one.
Yeah, there we go.
I wasn't able to download on my. Is it or no? This is the one from the old one.
That's the last one.
No.
Yeah, it didn't come out in the email. I saw these three.
Sorry. Oh, it didn't? I'm sorry.
Okay,
well, good. It came out as images, so it was kind of hard to download afterwards.
Just tell us about you can just do the introductory on the patient, and we've got the second page, which has the most information that we actually need. So
this is a 72-year-old male with known osteogenesis imperfecta. He is bound to a motorized scooter. He does not ambulate. and he's a white male. He otherwise is very healthy. He takes some Procardia and hydroxyzine. As a child, he told me that he's had 200 plus fractures. However, as an adult, he hasn't had a problem until now. And so in January of this year, he was on a cruise, and he was going downhill, and his wheelchair kind of flipped him, and he sustained a humerus fracture. It was initially treated non-operatively, but in August, he had to have surgical intervention for a non-union. He doesn't have any history of OI, but he does have one child that has it. Otherwise, like I said, he's healthy. Since surgery, he was started on cholecalciferol 2,000 units, ergocalciferol 50,000 once a week for 8 weeks, and then the calcium twice a day. He's never taken any form of bone-specific medication. He doesn't smoke. He doesn't drink. Historically, he says he's 4 foot, and he is 120 pounds. For the BMI 36.6, he's in his motorized scooter. I got a bone density on him. Truth be told, this is my first osteogenesis imperfecta patient, so I don't even, and he's got quite a skeletal deformity. I don't have pictures for the bone density, and I'm just kind of naive to this, but this was his T-scores that were reported out on his bone density that was resulting. Negative 3.1 in the lumbar spine, negative 5.4 and 5.6 in the left and right total hip, and negative 4.5 in the femoral neck. I didn't get vertebral imaging. He's not able to stand.
How old did you say he was? I'm sorry, since we don't have the first page. How old?
He is 72.
Wow, he's made it. He's made it all these years.
And he's been
wow.
in a so he hasn't, I guess, even had the opportunity to fall, and I guess from transferring, he hasn't had an issue, and he doesn't even, and I asked him does anyone follow him for this, and he said no, it's never been an issue. Now it's kind of just been a thing that he's coped with. He's high spirits about it. He's not really had any problems with it. I did do a FRAX score. Obviously, he was high risk, 37% of major osteoporotic fracture and 25 of a hip. His labs came back pretty benign. A little bit on his a little bit on his CBC, but nothing really exciting in terms of hemoglobin hematocrit. They were just flagged as abnormal. And his vitamin D was 72.6. His TSH was 1.07. His PTH was 32.6. GFR is greater than 60. Alk phos was 114. Calcium was 10. Phosphorus was 3. Albumin was 4.1. I did order a P1NP and a bone-specific alkaline phosphatase. They are pending. They haven't been resulted. My question really is, what can I do for him? Can I help him out in any way? I know there's not a ton of, or at least to my knowledge, there's not a ton of literature. Should I use an anabolic? I'd like to use an anabolic. Will it help him?
So the answer is yes. If you, at the ISCD, basically when we talk about these patients, it's one of those things that said, obviously you didn't even, you did the FRAX, but you didn't need to, because he obviously was, he obviously had the osteoporosis. I do think, the skeletal size is real important. He's a short stature. And can you clarify, did you say that he did have OI or he didn't have OI? I guess I didn't hear that part.
His osteogenesis imperfecta, he's known this since a child. He was diagnosed. Right. He was diagnosed.
So he has OI. So that means he's technically he's going to be at high risk no matter what. So basically using an anabolic that would be really, really important. And then the only thing we had in the past was the anti-resorptive to slow bone turnover down, but there's no real great answer here, but you want to try to maximize as much bone building as you can. So I would say yes, an anabolic, and then you would go to an anti-resorptive, and you just hope for the best. The problem is that you can't really tell him, you know, the goal here is fracture risk reduction with treatment, and you can't really tell him how much you can reduce his risk of a fracture. That's the thing. You can treat his osteoporosis, but you can't tell him if you're going to reduce his risk by 30% or, you know, because right now we can say 50 to 60% with most of our treatments, right, except calcitonin. But we can't say that to him because he has a metabolic issue. So I would say, yes, you could use an anabolic. Yes, you know, I would do that first and then go an anti-resorptive. If you're concerned and you're not quite sure where to navigate, you can always send him to endo. But I think an anabolic definitely is what I would do.
Yeah, I figured that, and that's what I wanted to do. I just that was okay. So,
yeah, no, absolutely. Mr. Phipps, do you have any comments today? I don't know if he's still on. I wanted to see.
Yeah, I'm still on.
Okay, you got some comments about this?
I think the sky's the limit on this. I don't think you can do much wrong here. My biggest thing was I think an anabolic is going to help him heal his fracture. I think if we can stimulate new osteocyte formation, that's going to help heal his fracture. I'm with you, though. I don't know that that reduces his overall risk very much.
Yep. Good comments. Other providers?
I would watch his calcium closely.
Watch his
calcium's kind of on the borderline normal high, so I would just watch that cautiously if I'd start him on an anabolic.
Yeah.
Is that, I mean, we do that in general, or is it a general recommendation, or does it, or because he has OI, does that put him at a higher risk?
No,
just in general. Yeah.
I didn't know if I mean, normally I cut back their calcium and I do monitor it, but I didn't know if I should be cutting it back more because of his OI, if there was any other higher risk because of that.
No, I wouldn't.
Okay, awesome. Thank you, guys.
Yeah. I know there's other comments. We've got smart people on here. I see your names. I know you people.
Well, I appreciate the help.
Dr. Wright, do you have any comments? She may have left her desk, it looks like. Yep. All right. Those are great case presentations. I want to just let everybody know, we want these case presentations. I learn every time I get on Project Echo and we hear these case presentations. I have some case presentations I need to get on there as well, but I just don't want to hog it because I have plenty. But we want to see your case presentations. Take the time to get on and fill out the little paperwork so we can help you have the best outcomes for your patients, because that's what the goal is here. So again, are there any other final comments? We have a few more minutes. I just wanted to see if there were any other final comments, questions, anything like that.
I'll just say thanks to NBHA and Clayton. Great job.
Thank you. Thank you for being on. So just be sure to fill out your evaluations so you can get your CME. And again, we thank you so much. What I want to do in the coming days as I work with Claire and Andrea is we really want to make sure that we are meeting the needs of our participants. And we want to make sure that we have topics that are on point of interest to you. We don't want to be redundant. We want to make sure that we are giving you up-to-date information. We know you're all very busy providers as we are, and we just want to make sure that we make the best use of your time. So you may see a survey coming out about topics of interest, time that we're actually doing FLS. We set up this time to try to get more people be able to come in on the West Coast as well. So we try to meet everybody's needs in that realm, but we want to hear from you, and we want you to spread the word. So, we might have a campaign, bring a friend to Project Echo, so have some more people get on board with us. So thank you again so much, everyone. This is so enlightening, and I love it, and I love the passion behind everybody. I love all my colleagues out here. It's great to have you all on. I'm going to turn it over to Claire or Andrea so that we can close it out. Thank you so much, everyone.
Thanks, everybody. And I hope you can hear me. I just sent a note to all with my contact information and Andrea's contact information. As Ann stated, we've had some executive changes here. We're going through a restructure, and it's going to be really good, and we're excited about it. But just wanted you to have our direct contact information as well. Again, the CME link has been posted to the chat too, so please go on and do that so you can fill out your evaluations and get your CME. We were able to record this, so we will have a recording of that. Andrea, anything I'm missing about follow-ups that we do after this?
Not really. There will be an email out tomorrow with the link as well for everyone here. So in case you didn't get it now, you can get it tomorrow. Make sure to complete that within a...
Yeah, and if you haven't, just make sure that your email is in the group chat so we can get that from you. But otherwise, we'll see you next month.
Okay, wonderful. Do we have a topic for next month?
We do, I think. Andrea? Hello?
Believe we do. And
I believe it was a
echo.
coding. I think it was a coding.
It might be.
Believe.
I don't want to say it wrong, so I'm not going to say anything right now. Just in case.
That's okay. Well, it's okay. Well, I just wanted to give them a heads up, but we'll send out the email. And
we'll send that out. Yep. We'll make sure everyone gets it.
For a survey in the next month or so. We appreciate all you all. Have a great rest of the day.
Thanks, everybody.
Thank you.
Thank you.
Bye.
Thanks for letting me talk.
Good job.